I'd like to welcome everyone to this, which is the second of our webinars and panel discussions, talking about different issues related to COVID-19. Very much appreciate that we have a really great group of panelists today. So I'm going to bring up the slides that we have developed, although most of this will actually be a discussion rather than a webinar or slideshow. But you can read more about the series at cph.temple.edu/COVID-beyond. We have recorded copies of prior webinars and also other materials that are being developed through the college. Just want to highlight something that just came out, I think, this morning, that Brian Lindberg, who's one of our speakers, has developed, talking about what's happening nationally around some of these issues. And you'll see there the URL in order to reach that. So this is COVID-19 Beyond the Biology, because we recognize that a lot of the attention, we recognize that a lot of the attention has been focused upon the biological aspects of COVID-19. In this series, we're really seeking to address what it means for people and the different things that potentially are happening or need to happen. So today we're talking about addressing the impact of COVID-19 on older Americans and the consequences of isolation. We talk a lot about self-isolation, quarantine. Those are great technical terms, but what does that mean day to day in people's lives? So I'm Philip McCallion. I'm a professor and I'm the director of the School of Social Work. And our panelists today are Brian Lindberg, who we are very honored to have as one of our alumni in the School of Social Work. And he's the executive director of the Consumer Coalition for Healthcare, based in Washington, D.C., and really working on protecting and improving the quality of healthcare for all Americans. Amy Gotwals is the Chief of Public Policy and External Affairs for the National Association of Area Agencies on Aging. They represent the network of area agencies on aging, but they're also a voice in the nation's capital for more than 250 Title VI Native American aging programs. And Andrew MacPherson, who's the managing partner at Healthsperien, LLC, which is a nationally recognized healthcare policy consulting firm that's focused on federal and state issues and on legislative policy analysis, advocacy, and implementation issues. So we're going to be talking about what the federal COVID-19 and stimulus bills mean for older adults. We'll be talking about the implications of advanced illness. We'll be talking about how nursing homes and skilled nursing facilities are responding to COVID-19. And in particular, we'll be talking about the issues of self-isolation and loneliness, which are clearly being magnified in the midst of our response and our needed response to COVID-19. So just thought I'd pull up some figures that I looked yesterday, and in Pennsylvania, where Temple is clearly based, there are 34,528 cases so far have been identified, with 1,564 deaths. When you look at the hospitalization rates by age, you'll see that those 65 to 79 and those 80 plus represent almost 40% of those who've been hospitalized. And that really speaks to that risk for serious consequences in COVID-19 are influenced by age, primarily those who are 70 years of age and older. But clearly, this is also a disease that affects people at all ages. But those 70 and older are at particular risk for serious consequences. And then a series of chronic conditions, which also increase with age many times, things like diabetes, cardiovascular concerns, cancer, immune disorders, respiratory disorders. And so when you look at this, you realize that older adults are at particular risk. And then recently, we've been looking much more at what's happening in nursing homes. And so, again, looking at figures yesterday, I pulled up a number of the counties that are in the Philadelphia region, looking at the number of facilities with cases of COVID-19, where the cases are among residents, the number of cases that are among employees, and the number of deaths. And the bottom line gives you the sort of total numbers that there are 396 facilities with COVID-19 cases. There are over 5,000 individuals who are residents of nursing homes who have COVID-19. There are 572 so far identified employees with COVID-19, and there have been 796 deaths. So it's a particular concern as we look at what's happening in nursing homes. And there's, as I said, more and more attention being paid. But what I'd like to do, and I'm going to stop sharing the slides and really ask Brian if he could talk with us about what's been happening in terms of the responses, particularly at the federal level. We've seen a lot of information about stimulus packages. There was another one yesterday. If you could tell us about that and tell us what the particular implications are for older adults. Oops. Brian, if you could turn on your mic.
Yeah, sure. Thank you. Can you hear me now?
Yep.
Yeah, thanks. Sorry, I'm having a lot of technical troubles today. My iPhone died. We're not getting the internet service we used to here anyway, so my wife has been supporting me with her phone, etc. So anyway, thank you so much for including me in today's webinar. And I want, Phil and Natasha, thank you for helping to arrange it. And I wanted to thank my DC-based colleagues, all of whom are in their own homes the last month or so. And we're experiencing a rather odd way of lobbying, doing advocacy, et cetera. I do want to just give credit to my Temple roots. The School of Social Work really laid the foundation for my interest in doing advocacy at the national level. And I've been doing that here in DC since 1983. Particularly having spent 10 years on the Hill on the House and Senate Aging Committees, this period is just so different. What we're experiencing, the trillions of dollars that are being spent, the thousands of pages of bills that are being written in a matter of days and weeks is just quite unique. And in an odd way, it's a privilege to be a part of that, but it's a sad time as well. It's very chaotic. And we sent a letter up to the Hill the other day, the Leadership Council of Aging Organizations, which a number of groups I work with are a part of. And it was nearly 20 pages of things that people believe need to be done right away. And they're not all going to get done. We're all going to face challenges serving our clients for a long time, but it is a privilege to be a part of that process. And what Phil shared with you, an article I did for the gerontology newsletter I do, GSA's newsletter I do every month, focuses partly on some factual information about the COVID bills, but also my view of the value, the importance of staff up on the Hill who are doing all-nighters, who are working all the time, who are showing their commitment to the causes they've been working on for years, but now in an accentuated form. So I hope you have a chance to take a look at that at some point. So let me, let's start with the latest breaking news, and that is that the House has decided to postpone its vote on changing its voting rules for remote voting. There's been a lot of discussion around members coming back into town, the safety of that, frankly, talking about aging issues, many of the senators and members of the House are older people. And so to the extent that they are part of a population that may do less well if they get COVID-19, there's been some, push to keep them back home. Many members now are getting very anxious. They want to show their constituents they're back in Washington working. Today, they decided in a bipartisan fashion, after some pushback, that they won't be moving immediately to virtual committee hearings and proxy voting. Proxy voting meaning, Senator Andrew, here, you can vote yes for me because you're in DC and I'm not coming back. I'm all the way out in Washington State and it's not safe or whatever. So they've decided to put a panel together to discuss that. So it's kind of, this is the way our days go. I mean, the emails just pour in and you can hardly sift through all of them. In this case, it was a little bit of a procedural update, but it was very interesting that there was enough pushback from both Democrats and Republicans that they weren't going to move in this direction. So let me talk a little bit about what has happened, what these staff and members have done in very short order. And we'll start with, I'll just mention the dates to give you a sense of time frame here. On March 6th, the president signed the first coronavirus preparedness and response supplemental appropriations bill. And that, to give you a sense of why they did that right away, it really was focused on the emergency aspects of this, the getting money out there to make sure vaccines were being developed, that the manufacturers would move forward quickly on that, some grants to states and local and tribal health agencies, preparations for emergency evacuations, and all of that got kicked in on that first bill. It really didn't address our, our clients, if you will, older people or others who are becoming ill. The second bill came along on March 18th. The president signed it. That's the Families First Coronavirus Response Act. It also provided some supplemental appropriations for public health emergencies. It had, you may recall, it had the first amount of money for older adults for nutrition programs. Obviously, congregate meal sites were closing down. They needed more money to kind of convert their operations into home delivered meals. That was $250 million. Subsequently, in the next bill, they got another $500 million for the meals programs. But that was the first sense of urgency, I think, from Congress related to older adults and nutrition. The SNAP program, the food stamps were included in that bill. Paid family and sick leave were included. And then on March 25th, so we're gone from March 6th to the 25th, we have the third bill. That's the giant bill that all of you probably heard about. It's called the CARES Act. It included $2 trillion in emergency economic stimulus. It included money for NIH, $945 million for NIH. It included resources for the CDC, and they've been at the center of trying to direct all of us, government and the public at large, on how to handle the pandemic. There was $275 million for HRSA. Those are employment, healthcare professional related programs. $200 million for CMS specifically for nursing homes. So in that package was really the big push to enable the aging network, and Amy's going to talk a lot about that, but it was the first acknowledgement, I guess, besides the meals dollars, that there's a whole set of programs out there, the aging network, led primarily by state units on aging and area agencies on aging, and their their service providers that they sometimes provide themselves and sometimes they contract out. In that package, there was, as I said, there was another $500 million for nutrition. There was $200 million for various supportive services that Amy's folks provide. There was $100 million for caregiver support programs. I worked with Congress to include two pieces that related to the long-term care issue, $20 million for the long-term care ombudsman programs, and language in that bill that provided or restated that long-term care ombudsman should have access to nursing homes, to residents within nursing homes. So let me just say a little bit. Well, Phil, do you want me to talk about the nursing homes now,
Sure.
or do you have some other questions you want to dive into?
Actually, why don't we turn to Amy, because you've talked about the monies that are being made to the Aging Network, and I think people would be interested in hearing about what the Aging Network is doing and what they hope to do. So let me just bring that slide up, and I'll advance the slides for you, Amy.
Great, thank you. All right, great. I'll dive in real quick on this, but I have to say my Temple connections, they aren't as strong as Brian's. I'm not an alum, but my grandparents on my father's side did meet there when they were in college in, must have been the 20s, maybe early 30s. I didn't have a chance to look it up, but the photos behind me on the wall over there, actually, there's a picture of them in these long leather sweaters and just fantastic attire, standing around with their friends on a Philadelphia street. So I've got that legacy going for me, and thank you for inviting me to join in today. A quick 101 on the Aging Network would probably the best thing to do is go to the next slide, where I put up the simplest, crudest chart here, but just to remind, and we don't do it top down because we recognize everyone has a key role to play. But when we talk about the Aging Network, we're talking about the federal agency with authority over the programs that we all work to administer, playing our different roles. That's the Administration on Aging, which is part of a broader agency called the Administration for Community Living, and they have that appropriate federal oversight role and administer these programs. And then the funding, and this is largely through Older Americans Act. I should have referenced that. The programs Brian's been talking about, this is the distribution channel and the service delivery network that then makes that money turn into actual services for older adults. So then there are state units on aging, and then the folks who are my members are these area agencies on aging, but they don't work alone. And if we did do it top to bottom, it would look an awful lot like a pyramid. You see the numbers are growing, the farther deeper into the system, the more community-based we get. There are service providers, mostly nonprofit, sometimes for-profit. We work with a lot of different partners to achieve the delivery of these services, but largely nonprofit organizations that tend to focus in on one particular aspect of aging service delivery. So the next slide is a little just, am I supposed to, Phil, keep going on about AAAs or just that piece? And we're gonna
just keep going.
Just keep going. All right, great. It's usually hard to stop me when I start, so just probably a good decision. So the thing that our area agencies on aging have in common is they are responsible. They were added to the Older Americans Act in 1973, and they play a specific role that's different than a traditional service provider, and obviously very different from states, although there's some commonalities, and that is they are on a regional basis. It may be just one county, it may be across 9 counties. They have a planning and service area where they're responsible for developing plans around aging. What is that local plan for how we're going to create the services and supports and support older adults on their healthy aging journey, whatever that looks like, then developing the actual services and those who can help deliver them, coordinating and overseeing that network of providers. So again, we're back to the CBOs, the community-based organizations, service providers that work with the AAAs to do this. And as Brian made quick reference to at one point, sometimes in our more rural areas or other under-resourced areas where there aren't as many community providers, then in that case, the AAAs deliver direct services like a meals program or a transportation program. But there are some services that AAAs do provide directly. That's part of their role in doing all this. So on the next slide, we'll talk a little bit about what these services look like. And again, I'm going to speak from the AAA perspective, but I'm recognizing the role of the feds, the states, and our community providers as well. But under that Older Americans Act, there are 5 core services. There's nutrition programs. Those are the very well-known home delivered meals programs. And there's congregate programs, which are a little bit less well-known, although they shouldn't be. You know these happen. People just think of them as something that senior centers do, but they take place in a range of community settings and are very critical. Health and wellness, that would include the evidence-based health and wellness programs in the Act that address falls prevention, chronic disease self-management, diabetes self-management, and late life depression. Supportive services, just some of the things that includes, because that's a really long list, is personal care, case management, transportation, home modification, legal services, and chore services. Caregiver supports, those were added to the Act in the year 2000 as part of a reauthorization of Congress updating the law and in response to emerging interest in better serving the family caregivers of older adults. And those types of supports include education and support, respite care, emergency assistance, etc. And then another important, although very underfunded portion of the Act is the elder rights component, which is to prevent elder abuse, as well as the long-term care ombudsman program that Brian mentioned, the one piece that focuses on older adults who are in institutions. Really, the thrust of all of these services, with that exception of the long-term care ombudsman, is to ensure that older adults who are aging, choose your term that you like best, aging in place, aging in community, aging well. You can call it what you like, but the way that most of us would like to age, which is to remain where we are or find something more suitable and accessible, but still in our own homes and in the community. And these services are really set up to be able to support people in doing that. These are not the only services that AAAs or the Aging Network deliver. They also work extensively to deliver Medicaid home and community-based services, which look a lot like these icons and descriptions here on this slide. So it's an Older Americans Act is not the sole funder. There's certainly also state and local dollars that are leveraged along with Older Americans Act to really create a flourishing. The next slide will just remind us that despite all that commonality and common purpose and mission, there is some variation around the country because AAAs were added to be able to localize the delivery system for Older Americans Act services. That certainly led to some healthy amount of variation. So for example, states where they're very state-run system, like I'm thinking Pennsylvania is one of the ones that comes to mind. Pennsylvania, New York, county heavy, I said state-run, I didn't mean that. I meant county-run, very reliant on counties, very passing power down to counties, very divided up that way. Because that's not the case in other parts. There are councils of government or other ways of organizing that more local government aspect. And so depending on what that state's already existing culture was for divvying up this type of work, that affected where the AAAs sit. So on the next slide, you can see that they sit in different seats, that those county-driven states, Pennsylvania, New York, they, and many more, because 1/4 of AAAs actually operate within a county government system. They are still a designated area agency on aging, but they reside there at the county level. Another, about the same amount, a little more, are those councils of governments. I mentioned before, you often see these in the Southeast and in the West. And then a healthy 40%, thereabouts, I'm rounding up, are independent nonprofit area agencies on aging. So that does affect a little bit. It affects their name. It can affect some of their operating protocols, but the mission remains the same across the AAAs. Next slide. So that's who we are in regular times. I want to be very candid about where this network is, and of course we're, as a membership association of AAAs, are hearing that perspective most clearly, although working with allies across the aging network, such as how I I'm here today through working with Brian and Andrew and others, because let's face it, this challenge means we all need to be on board and reducing duplicity and enhancing efficiency to find any friends we can to help us meet these challenges. And they are big. This is just a list of what has been our life for the past 5-6 weeks, a little longer for some of our members. Some of our members are a little different stage of the process given where they are in the country. But this new reality of COVID has really obviously upended the services of AAAs. It's created these service delivery issues as well as administrative issues. I mean, the first thing to hit was the fact that the congregate meals programs, adult day programs, activities taking place in senior centers, that immediately, the closures of those, which is, I would argue, is sort of the first thing that happened. And they often closed before a lot of other businesses and a lot of other, the rest of us all packed up and went home. This left millions of older adults without their vital, regular connection points to the community and access to healthy aging activities as well. So it had a tremendous effect there. And these closures, coupled with the fact that a lot of the services, it was really on my slide of icons, the one that's supportive services, or I could argue caregiver respite, services provided in our people's homes as well. So that's a huge challenge to find out how you keep your eyes on your clients, continue to assess issues of health and safety, and meet their needs when everybody's saying, let's not get more than 6 feet apart. So that's been obviously a tremendous challenge for AAAs to figure out. You know, while the rest of the world, those of us all equipped, all of us on this webinar, because we're all zoomed in and using technology to be able to have this conversation today. But given the older adult population, particularly those folks that AAAs currently serve, this is not as easy as it is for all of us. We're able to do this pretty easily, Brian's phone challenges notwithstanding. I'll just give you one example just to reinforce this. But those of you who have lived or currently live in rural areas probably already understand this better than most, or any of us who have been supporting older adults and meeting their technology needs during this period particularly will appreciate that there was an Iowa AAA who recently surveyed its members on your preferred communication method. What is the primary way that you are, during this crisis, staying connected to others? What is your main way? And 60% of them said, I solely use my landline. So that doesn't fit with a lot of the other narratives that are out there on how to stay socially engaged. So we certainly know that is a huge challenge as well. How do you even had the money for technology that many of our organizations are lobbying to get out to the aging network? How do you begin to teach that to an older adult without being physically present in their home? These are things we're going to have to figure out. And then I would also add another challenge, and this should be a good thing if we can help more people with the resources that Brian mentioned that are pouring into the network, some of them as we speak, getting out to the field, is that there are a lot of new clients whose social support systems have collapsed with COVID. So they may not have needed the aging network services before, but very much do now as they continue to stay at home and try to stay safe. They may need more support if their caregivers can't get to them, if you know, fill in the blanks. And then I would raise two other barriers, and then let's talk about what they're doing to react to them, because that's the inspiring part here for me. The other barriers have been around older adults' fears. A lot of AAAs reported challenges in educating the older adults they were reaching. They were getting very bad information from television networks, from those who were connected online, from social media. They did not, the older adults they were trying to educate about how services would continue did not necessarily, they either weren't scared enough or they were so scared they wouldn't let their in-home care workers enter their homes, even if all precautions were taken, which is a challenge, because one thing to note, while the home delivered meals and all the wonderful work that goes on there gets usually the most attention as the most well-known service in the Act, these in-home services that are being provided, this is the difference for these people of whether they can continue to live independently. I'm talking assistance with the activities of daily living, assistance with toilet, all of those, which if you're not familiar with those, I'm sure you are, but toileting, bathing, dressing, just staying safe and well and going through these things that the rest of us often take for granted. So we've got that challenge. And then of course we're seeing scams and frauds. And so there we have to balance the fact that we're saying, hey, stay connected. You should be talking to more people. You should do this and that, with the messages we give them all the rest of the year on being careful who you talk to and how you engage. And then the last barrier I would say is that, and this shouldn't come as much of a surprise, but it needs to be said, the Aging Network relies heavily on volunteers for home delivered meals, but also for insurance counseling for Medicare to figure out which Medicare plan you're going to get. They rely heavily on volunteers, and those volunteers are largely older adults themselves. So we've seen tremendous challenges in retaining them and then filling in those spots. So my last slide, or whoops, two last slides, speaks to what they've done in response. And so let me just take a few more minutes to highlight this, because a lot of this is both, it's exciting. No one's saying these are all best practices. I want to be clear. Normally when you have a webinar like this, it's after lots of research, whether it became an evidence-based program or just a well-respected, well-vetted program, we talk about best practices, right? These couldn't be more fresh and emerging practices that we're seeing. We will do the work later to find the very best of the best and figure out if that also helps and is a good approach in this whole new world we're going to come out on the other side of this in. But it is really important to recognize this is them figuring it out on the spot. And the first thing the Aging Network did, and I give credit to all the nutrition providers working with AAAs on this, they had to pretty much overnight stand up grab and go programs for those older adults for whom that congregate meal site, coming there for lunch every day, was a vital part not only of their connection to community, to see their friends, for someone who checks on them, how are you feeling today? All of those connections to community, but also for that meal, for that nutrition. And they had to immediately switch, trying to get these older adults, many of whom they have low incomes by and large. These are not means tested programs, the Older Americans Act, but they are targeted at those who most need them. And so you can imagine, so now you're trying to, all the stock up that probably most of us were doing personally, but this is the same time we told our adults not to go out in public. So or they didn't have the funds. So how do you get food to people? So this was what the Aging Network has had to figure out, new ways of doing this. You're not going to come into the home and put the meal on the table, but can we get it to the door? Can we scrounge up enough PPE to do this safely? Can we recruit new volunteers? You get the point. And they're also venturing into things beyond the strict Older Americans Act programs to meet these needs too. You may have another group of folks who really could prepare their own meal, but they have no way to get groceries. So we're seeing lots of creativity, I'll leave it at that, in figuring out how we build this on top of the infrastructures and the provider networks that already exist. People are going beyond all the things that a lot of us are just zooming up on, that's not the word, calling up on our phones and having delivered, or we already got prescription drugs via mail. What do you do for older adults for whom that wasn't their norm? Their norm was going out into the community and getting these supplies. So I want to talk a little bit about combating social isolation, because we all, this is the focus today, and this is a huge challenge even without COVID. We're figuring this out. Yeah.
Amy, this is Brian. Sorry to do this, but I'm wondering.
I've used my time.
Yeah, but I just thought maybe, Phil, we should let Andrew jump in, since he's the star of social isolation in Washington, D.C. And then you can add some things, Amy. Would that work?
That works beautifully. Thank you, Brian, for the suggestion. I need a pause.
Okay. So yes, so let's turn to the star of social isolation.
No pressure.
Well, no pressure, Andrew.
Yeah, well, look, thank you so much, Phil and Natasha, for having me today, and for Brian for inviting me. I have absolutely no connection to Temple, but except that one of my mentors, who's right there in front of me on the screen, Brian Lindberg, is one of your graduates. But thank you very, very much for having me today. So Andrew MacPherson, I'm the co-director, in addition to leading Healthsperien, our consulting firm, I'm the co-director of the Coalition to End Social Isolation and Loneliness, which is a multi-stakeholder coalition based here in Washington that is advocating for to remove policy barriers to address the national crisis, which was occurring pre-COVID, related to social isolation and loneliness. Particularly, we represent, we focus on all populations, but particularly populations that among older Americans. I wanted to actually just start, Phil, with some definitions,
Sure.
because I think the terms of social isolation and loneliness tend to bleed together when they're actually quite different. Social isolation is a quantitative measure. Social isolation occurs when individuals do not have the opportunity or are not able to have social contacts or social connectedness. So it's a quantitative measure. Loneliness, on the other hand, is more of a subjective qualitative measure that's often described as having a feeling of isolation, not belonging, or lacking companionship. So there are two very different notions that often act in concert with each other. Obviously, the COVID-19 crisis is exacerbating what was already a national crisis that we were experiencing in this country. Studies show that nearly half of Americans report sometimes or always feeling alone, 46%, if you can imagine. Generation Z, I know we're talking about older Americans today, but Generation Z, 18 to 22 years old, is actually the loneliest generation, and claims to even be in worse health than some older generations. So this was a problem that was of just extraordinary magnitude even before the coronavirus national emergency and pandemic occurred. An AARP study actually showed, if you think about not just the prevalence of isolation and loneliness, but if you think about the cost associated with it, studies have shown that it costs the Medicare program, social isolation costs the Medicare program upwards of just under $7 billion per year in additional costs. In addition, there's a range of co-occurring chronic conditions, diabetes, chronic heart failure, depression, and a range of other mental illnesses that are co-occurring and exacerbated by social isolation and loneliness. And so you can imagine then with the COVID-19 pandemic that this issue is just exacerbated in a way that, frankly, we're just beginning to learn about, Phil. I know when we had talked previously in the lead up to this webinar, you and Natasha were hoping we could talk about some of the statistics that we're seeing related to COVID-19. Well, we're just beginning to establish sort of a baseline for what those numbers look like. Kaiser Family Foundation has put out, they have a monthly tracking poll, healthcare tracking poll that they put out, and they've been doing actually more regularly than once a month. And we saw when older Americans were asked about the negative mental health impacts of the coronavirus pandemic. Do you feel more worry and stress, for example, and is the coronavirus pandemic having a negative impact on your mental health? In 1 week, it went up 15% to about half the population. That was from March 15th to March 25th. That's an extraordinary number. So the mental health impacts of the pandemic are very real, and social isolation and loneliness are a major component. Asked, I actually broke down whether it was a minor impact or a major impact. About half the population says that it's having a major impact on their mental health. And if you break it out by different demographics, looking at, for example, looking at different races, African Americans, about 10% more are feeling the negative impacts of social isolation and loneliness and mental health as it relates to the coronavirus pandemic. Hispanic populations feel it much more. So when you really look at the numbers, this is an extraordinary moment that we're experiencing here. That being said, what we're learning from our members, and our members range from the largest health plans in the country to major consumer groups, also tech innovators like Lyft and Uber. What we're hearing from them, and Amy touched on some of this, is that there are interventions that are helping, right, to address the negative mental health effects of isolation and loneliness. One theme across all those interventions that we found is keeping, maintaining, or finding a sense of purpose. And that one really struck us internally is what does that really mean? Well, maintaining the things that brought you happiness prior to the crisis to the extent that you can. Things like the hobbies that older Americans had related to the extent that you could still garden, for example, to the extent that you could still connect through technology with your family and friends. Maintaining a sense of purpose is one of the most critical elements of maintaining one's mental health throughout this crisis. The other that I'll just touch on and then I'll conclude is physical activity. Obviously, we are quarantined. Obviously, there's a lot of restrictions on our movement right now, but there's a lot of ways to have age-appropriate physical activity throughout the crisis and the national emergency. Studies have shown that despite all the different interventions, minus, outside the pandemic, when you look at all the interventions to address loneliness and isolation, the number one that the evidence shows is physical activity. Get out, go for a walk, go for a jog. Any sort of physical activity is a really important way and strategy that we can use to address the crisis. So I'll stop there and happy to answer questions about some of the policy aspects of this, Phil, but I'll stop there and turn it back to you.
So we had a question, and I'll pose it to you first, Amy, in terms of how can participants, in what ways can the elderly or their caregivers access the resources that are being made available, particularly these additional resources that are being made available?
Yeah, sure. So they would just really need to reach out to their local area agency on aging. And I made quick reference to it before. These agencies don't always have the same, they don't all put area agency on aging in their name. So it's a little tricky, but luckily the federal government funds a national toll-free line, and we can, because of course I didn't write this down before I got on screen right now.
Okay.
I'm pretty sure I know it, but I don't want to say it wrong. So I'll look it up when someone else is answering a question. It's the Elder Care Locator. So if you aren't sure in your area how to reach your area agency on aging, although they all have local toll-free lines as well, you can certainly call it. It's my colleagues also at home, but with headsets on, answering calls from consumers. So that's the quickest way to find out where those local resources exist. Because as I think both Brian and I have stressed, like these services are, the funding that's coming will certainly be used to support existing clients, but there is actually a lot of it, understanding how many people are now affected. So there is opportunity, may not happen that fast. We certainly got lots of demands on the network to get people pulled into the right programs, but that is continuing to go on. Everything is still operational. So I would refer people to that Elder Care Locator online. It's eldercare.acl, the federal agency that governs it, .gov, eldercare.acl.gov, and I'll get you the phone number.
Okay.
Phil, could I also add that we've developed on our website, which is endsocialisolation.org. We have a resource center that we've put together, building on the expertise of our members, including national organizations like the American Psychological Association. We have a resource center for individuals, and it's just /COVID-19 that has a whole range of resources that people can scroll through and on a whole range of different issues. So I encourage folks to check out our website.
Okay. And for people who are listening in who are in the Philadelphia area, in the city of Philadelphia, it would be the Philadelphia Corporation for the Aging. And then in the surrounding counties, it will be their county office for the aging, because as Amy said, within Pennsylvania, it tends to be county-based. I don't want to forget about nursing homes. So maybe, Brian, if you could say a few words about that.
Sure, I'd be happy to. And of course, one of the biggest nursing home problems is isolation right now as well. Mm-hmm. Let me start with what we're hearing out in the field. I work with the National Association of State Long-Term Care Ombudsman Programs, and so as the various states have been hit with surges with the coronavirus, we've been in contact with those ombudsmen, starting with Washington, where we heard, the horror story of not being able to access the nursing home, not being able to tell loved ones whether their family members who were residents of the facility were still alive, the facility not providing good information to anyone. I've talked with the New York Ombudsman, who had 6 ombudsmen serving New York City, 55,000 residents in 400 nursing homes, and trying to keep up with the status of those, actually becoming, if you will, a social worker for administrators of facilities who were losing staff to the coronavirus and because they were sick, and then actually having several staff people pass away. The director of nursing in one facility died. The horror stories we're hearing in New Jersey just continue this. It's so typical now that since we don't have good access to the facilities, and ombudsmen don't want to go in facilities and bring the virus in and or get it themselves being in the facility, but we really fought for some access in real emergencies. The problem, of course, is we don't want to take personal protection equipment, PPE, away from staff of a nursing home or anyone else who's in the healthcare profession who needs it. So it's very complicated. But New Jersey, you've probably seen some of the details. What we're hearing typically now is that a family member gets a call from the nursing home saying your loved one has COVID-19 and is ill, and then 24 to 48 hours later, they get another call saying the individual has passed away. It's often very quick, and there's no opportunity because of the CMS rules. Residents can't have family or friends coming in. So this person more than likely passes away alone quickly. And one of our real concerns, and I don't know if Andrew will have time to discuss some of the advanced illness issues that are, advanced care planning issues that are relevant, but we're really concerned that those residents in these facilities are dying without the appropriate comfort care, the palliative care that they could, at least in a hospital, because it's happening so quickly. Staff are overwhelmed. Some aren't there, so it's understaffed. We all know that staffing is the most important element of quality nursing home care and has been for decades. We've known that. There's the IOM study from way back when. So in a case like this, we don't have the staff. So a couple things are happening. Just to mention one, there's a LCAO, Leadership Council of Aging Organizations, push now. We've got a letter up to the Hill to try to get the technology grants to facilities so that they can enable their residents to communicate with their family, their loved ones, which we feel is really important. These would be grants to nursing homes to do this. The ombudsman have been extremely busy just on the phone to the nursing homes, which is very hard to find out information about individual residents, and then back to the families. If we could hook them up in that way, it would be very helpful and reassuring to families who really are just losing their loved ones overnight. So I know we're running out of time. I don't know if you want to open it up for just a broader discussion of social isolation,
I see if
nursing home issues.
Yeah, if I could switch back to Andrew, one feature that has certainly gotten a lot of publicity is really the loneliness of death kinds of issues. And as Brian was bringing out, the issues around advanced care planning, and wondering if you had some thoughts on that you would share.
Yeah, no, I'm happy to. And I also wanted to comment as Brian was talking, I think, the death issues obviously are getting a ton of attention, but I think an issue that's not getting enough attention that we also need to focus on is the number of elders who are living through this, right? And what their mental and behavioral health needs will be in terms of the grieving process, grieving frankly, that we're all going through, and sort of what their needs and what resources we can put into supporting them, and survivorship related to COVID-19, I think is not getting enough attention, and something that we need to focus on. With respect to advanced care planning, only about just over 20% of Americans going into the pandemic had expressed any sort of wishes in writing about what their end of life, what they want their end of life care to look like, Phil, which is a major problem in this country. That number is a little bit higher for Medicare beneficiaries. It's just over 30%. But we haven't done a good job in this country of having a conversation, a sort of rational conversation about what it is that we want in our life when we become seriously ill. So that's where we were before the pandemic.
Right.
Where we are today is there are still financial barriers to having an advanced care planning conversation with your physician or allied health professional. You still would have to pay the coinsurance, for example, for the Medicare visit. You still would have to pay the deductible in Medicare Part B. Brian and others, organizations in Washington, myself, are advocating with the Congress to try to remove all financial barriers, just like we have with treatment and related to COVID-19. Remove all barriers, financial barriers to individuals, at least on a temporary basis, to have that meaningful conversation about what it is when you're seriously ill. And I think our hope is that the Congress in this next package will include language to remove those financial barriers and encourage providers and individuals to connect and have that sort of values-based conversation. We also think it's possible that CMS, the Centers for Medicare and Medicaid Services, Medicare, could do that on their own, that we might not even need Congress to remove those financial barriers. So again, just like social isolation and loneliness, all of these issues that we're facing as a country have become so much more exacerbated as a result of the pandemic. But I'll turn it back to Brian.
Phil, could I just mention, Andrew's, one of the founders, really, of the Coalition to Transform Advanced Care. And our top 3 priorities right now relate to advanced care planning. The second one relates to the fact that the docs can bill for Medicare for the advanced care planning conversation, but clinical social workers and registered nurses can't. That's the second one of the 3 pieces we're pushing. First, get rid of the copays, allow social workers and nurses to do these discussions. They do them better anyway, frankly, in most cases. And the third is really just making sure that if one shows up to any healthcare facility with any kind of an advanced care planning document, that it doesn't matter what state it was written in. The healthcare facility should be have no liability for using a document maybe that came from New Jersey, but the person's getting their care in Pennsylvania. So that reciprocity is really important to us. Those 3 pieces we're really pushing for in this next package. And Amy, you may want to just mention a couple items that we're pushing for in that package related to social isolation.
Sure, thanks, Brian. In addition to the dollars that Brian already detailed, we're realizing, and he gave you such a great sense of how quickly this has happened and the size of the dollars, but also the speed at which this is rolling out. And so, and my remarks really focused on what do you do when it's shutting down tomorrow? So now that we're more than a month into this, the attention is turning to, so how do we sustain these services? How do we bring in new ways to reduce social isolation with new partners and new volunteers, and all of that is starting to happen. And I think what we recognize, just as Brian's example with the nursing homes, if you don't give people the funding to do this, they can't just buy enough iPads to make this work or secure the technology in a community that doesn't have access to broadband. So we are asking for $80 million. This is just my organization, but others are echoing these requests, and one to varying degrees of exactitude, $80 million for technology in funds to come into the aging network to help bridge and connect people back out into the world with older adults. We're trying to keep it flexible because, as I said, these are emerging practices, not solid best practices. And as well as that, the work of the coalition that Andrew leads, the Coalition to End Social Isolation, and Brian works on as well. They did a lot of work in the last update of the Older Americans Act, which finished right in those first crazy weeks when we were all heading home, just in March. That actually got through Congress right before everything broke. But what it did is it puts particular emphasis on reducing social isolation in the act in a way that it wasn't before. It was always inherent in our work, but it didn't spell it out. It didn't have a report to study how we did it. So that was incredibly fortuitous that we had Congress already on board to increase activities around this. The trick is, now we just had some of our great vehicles for reducing social isolation knocked out from under us in the aging network. So how do we do it? And so I'll just really quickly say the pieces I didn't get to, because I don't want you to think it's all meals. That's an emergency need that has to be met right away. Sure. Then what do you do beyond that? They're setting up telephone reassurance lines, ways for people to call and get volunteer matched to an individual who will check in and will make sure they have what they need. Because the service network of paid staff and even volunteers can't meet all of these needs. So how do you have widening circles of people connecting? How can we move things telephonically and of course online where possible to have people stay engaged? New York State has poured some money into animatronic pets to deploy those out for older adults for whom it's still not safe to come out, particularly those who live alone, particularly those with cognitive challenges or mental health challenges, to be a source of comfort and connection, even if it is to a robotic cat or dog. So there's lots of creativity going around out there, and lots of ways for, I would argue, students to get involved. One of the ways with those older adults volunteers declining, one of the things we've seen patterns in different parts of the country among AAAs, they needed background checked volunteers to do some of this work. So they turned to the at the time, less employed teachers, and soon again, not busy teachers. They turned to county employees. They turned to, in one case, nursing students at a University of Washington, one of the Washington universities. They did the telephone checks. They got credit for participating in practice hours, and they were doing the direct outreach to like every list of every older adult AAA had ever served. So they may not be current clients, just to check in and then refer back to the aging professionals if there's a need. So I think all of us are going to need to find ways to patch into this. There's not one solution, but we need everybody's best eyes and putting in the time to help older adults through this and on to the other side of the crisis.
I feel like we could talk. I feel like we could talk for another hour, but it's my job to sort of bring things back in again. So I want to thank each of you. You've given us a lot of things to really think about, and yeah, I have to express my appreciation for the work that each of you is doing, because these things, as you've all said, are happening very rapidly. We're all trying to cope with all these changes that are occurring for us. It's a time when people could take their eye off the ball in terms of how do we support older adults. And it's people like each of you that are, despite all the challenges that all of us are experiencing, are making sure that the voice of older adults is heard and that the solutions that people are coming up with respond to their specific needs as well. So thank you. So I'm just going to finish up with just a few slides, and it'll take me just a moment. You know, because we are very determined as well to keep things moving in terms of our responses to this, as well as the issues that are happening in the communities around us. There's issues that are happening for our students as well. It so happened that our Temple Toast Day is coming up tomorrow. This was planned long in advance. We had lots of other things we were going to encourage people to donate to. What we're really focused upon is scholarships and student emergency aid, because day to day, that's what's going to make the difference for our students. But we also want to continue to be a resource around coronavirus. And so this is the URL to the webpage that we have developed. These webinars will be there. Other resource materials are there. We have some great videos on hand washing. And at the end of the day, this is about sort of these very basic things that will actually make a huge difference. And if in fact we start opening up communities, we've got to get those messages out to keep washing our hands and to keeping physical distance. Again, I want to thank each of you for your contributions. Again, I think we could have talked for another hour easily. And I intend that we will continue to reach out to you and find ways that Temple can be part of the solution as well. So thank you very much.
Thank you, Phil.
Thank you. Take care.